all know revisions are done for all these conditions and they are increasing. The projected increase is almost a 300% rise. This is US data, but I'm pretty sure in India we are seeing, especially the seniors, that all our hospitals are suddenly seeing a flood of revision work. What reason? Probably that should be another talk. And the aim of a revision surgery, we all know, is to improve the function, have a good long-lasting joint, and must reduce the re-revision chances. We know that the loosening happens because of the osteolysis, and both the components, they have a different rate of osteolysis. Most of us will have one component which is stable and the other one is relatively loose. And for that, it's very easy when both the components are loose, take it out and a revision is straightforward. But the controversy happens when you want to retain the stable component or part exchange it, or you have to finally remove it for reasons. That is what we will be discussing. So the surgeons usually like to not change the component to reduce the operating time, to preserve the bone stock, obviously lessen the blood loss, and especially in India, lower the cost. Whereas if the surgeon wants to remove the stable component or part change because of problems of exposure, want to correct some sort of instability reasons, want more choices so that you can have types of implants to match whatever is your construct design. And we want to use the newer technology to have that benefit. This has been discussed, how difficult it is to remove the well-integrated stem. Obviously, I will not repeat it. I've borrowed this case from Dr. Kharbandas, that this was a dissociation of the modular THR. On opening, this has been just shown that this had huge stenosis. It was correctly revised. The acetabulum part was not touched, so only a selective change of implant was done. It did so well for many years, but unfortunately, this stem had a fracture, which was again revised and is doing perfectly now. So from the literature, now the next question would be, okay, I'm revising the stem size, what happens to the life of the acetabular socket? So for multiple studies are supporting that you go for a femoral stem, do a good job, the acetabulum, if that is well integrated, nothing will happen to it. And in fact, long-term results are also now supporting the same. But in some cases, say you see some amount of osteolysis around the femur, early detection and a grafting will salvage that situation. You don't need to remove that stem. Things are a little different on the acetabular side. So a good quality X-ray, you must pick up that there is wear happening to the liner, change it. This is after many years of the primary, did well for many years again, and it again worn out. Very young patient, rheumatoid. Again, the cup had already osteointegrated. Just a liner change, you can see that some of those screws have been removed, and again, this did well for many years. Another example, you can see the survival of a well-integrated shell is long. You just have to take care that identify the areas of the lytics that are forming, identify early. You can remove the screw and graft it, or make a window there, and you can use any of the standard grafting techniques. This will do long-term very well. So retention of this socket, even if you are having large periacetabular osteolytic lesions, appears to be satisfactory and the longevity is good. This is, say the lytic areas are now becoming bigger and the head is migrating inside. By the time it reaches the surgical department, this is the picture, and on the CT you can see there is hardly a shell of bone only left, a good impaction bone grafting. While retaining the stem side, you don't need to do a complete changeover. So be selective and this will last long. But in case there is a breach in one of the columns, you need to reconstruct it still better. And this stem side does not need to be changed. The head, however, was changed at this time. So literature again is supporting that isolated cup revisions will give a stable, with a stable stem, will yield very low re-revision rates. Little, 2-3 slides, sir. Some of the literature is supporting that there is no dislocation when you're doing just isolated implant revision. Some are saying no, the chances of dislocation can go up. To reduce those chances, if there is a good integrated shell, now even with these dual mobilities, they can be either cemented or you can, as a final rescue, use constrained liner, like in this case, which had a very bad experience, and finally, because of the neurodeficiency, a constrained liner had to be used, but literature does not support this for long-term good results. This is a good study which has analyzed previous studies and has shown that an isolated femoral side revision does not affect much the acetabular side, and the longevity is pretty good. Although the studies for femur side are less, but they are concluding that it is not justifiable to go for a complete revision. So to summarize, revision and re-revision cases are on the rise. Regular assessment, both clinical or radiologically, is must and recommended. At least recall the patient's X-ray once in a year. If there is any osteolysis of any side component, please graft it early so as to preserve the THR. Part exchange, as far as possible, use of these newer technology and constrained liners, I'll say, would be for salvage. An isolated revision of any side done satisfactorily will give rise to a high revision-free survival rate. Thank you all and best wishes for 2025.